All right, so this is chapter 35, environmental emergencies. This chapter goes over exposure to cold, heat, water-related emergencies, high-altitude emergencies, and bites and stings. It is a fairly straightforward chapter. Yeah. So all of these things, just kind of looking at this outline here, all of these things are something that's pertinent to the area that we live in. Exposure to cold, yes, absolutely. Exposure to heat, have you been in Wisconsin in July? Yes, we get exposure to heat. Water-related emergencies, I think most every town in this state has some sort of body of water. High altitude, not really, but we'll talk about it. Bites and stings, yes, absolutely. All right, so kind of going back to things. So hot and cold related injuries. Now, it might surprise you to learn that most of our hot and cold related injuries are not when we have extreme heat and not when we have extreme cold, but it's in those awkward kind of transition times, the spring, the fall, when people just aren't wearing the appropriate weather dressing, right? They're not wearing gloves. They're not, they didn't bring a coat because they thought it was going to be warm. Those types of situations, all right? It's in those weird transition times. Not to say that we don't get hot weather emergencies in the summer and we don't get cold weather emergencies in the winter. We certainly do, but we get a very big influx of them during those transitional times. Water-related emergencies, like I said, we have so many different types of natural bodies of water in our area, rivers, lakes, streams, ponds, everything. But remember, water-related emergencies don't have to be in those lakes, rivers, and streams. They certainly could be in the bathroom at home if you've got a tub, or even in a sink or a backyard swimming pool, right? We do get called a lot for those. High-altitude emergencies. So we're at, what are we, like 6,000 feet, 4,000 feet, something like that? Nothing too crazy. But you never know where we have visitors coming from. They could be coming from sea level. And they could potentially, have issues when they get here, right? Bites and stings, we mentioned that as well. Really? Only, Mitch says 1,200. I really thought it was more than that. But anyways, you get the idea. We certainly could have some high altitude emergencies. So exposure to cold. This can happen in any setting, whether it's wilderness or in town, out of town. Doesn't really matter. It can happen any place. Exposure may not be the only danger. So oftentimes our patients are experiencing something else, whether it's a pre-existing condition or it's an emergency condition that just popped up. For instance, somebody out for a walk has a stroke, and now they're outside also having a stroke in the cold weather. That's an issue, and there's two things that we have to deal with in that particular situation. Or maybe they're outside in the summer and they fall and break their leg, and now they have a broken leg, and they're also experiencing all of the hot weather. Your body loses heat. Back to the cold weather here. Body loses heat in several different ways. There's 5 different ways, actually. Conduction, convection, radiation, evaporation, and respiration. And I went through those very quickly because there's another picture here that I think does a good job of explaining exactly what all of that means. So radiation is where the body heat is lost to the atmosphere or nearby objects without physically touching them. Convection is body heat that's lost to surrounding air, which becomes warmer, rises, and is replaced with cooler air. Respiration is heat loss through exhalation of warm air and inhalation of cold air. Evaporation, which is perspiration or wet skin resulting in body heat loss when the liquid evaporates. And conduction is body heat that's lost to nearby objects through direct physical touch. Those are the 5 ways. Exposure to the cold reduces body heat. The body's unable to maintain proper core temperature, may lead to death. Predisposing factors, anytime the patient is under the influence of drug or alcohol, they've had any serious injuries, infections, or immobility issues, diabetics, all kind of increase the likelihood of having hypothermia, as well as like age. Very young and very cold, or very young and very old have increased likelihood of hypothermia as well. Okay. So assessment of a patient with hypothermia. So shivering is kind of early stages of hypothermia. They might have things like numbness or reduced loss of touch, stiffness or rigid posture, drowsiness, rapid breathing, pulse, slow absent breathing, pulse in prolonged cases, loss of motor control or function, joint muscle stiffness, decreased level of consciousness, or just generalized unconscious. Cool abdominal skin temperatures, red skin, pale cyanotic skin in prolonged cases. Okay. So in these situations, what are we going to do? Well, with our patients, we're going to make the decision as to whether or not we're going to actively rewarm them or passively rewarm them. Passive rewarming would be covering the patient, removing any wet clothing. Active rewarming would be applying external heat sources like a hot pad or a hot pack to the patient. In general, we also want to make sure that we are removing any and all wet clothing, actively rewarming patients that are alert and responding, providing care for shock, and if they're alert, we're going to give patients warm liquids at slow rates. Now, I caution you, anytime your slides say give warm liquids, you should always take that with a grain of salt. If our patient is going to the hospital, we probably don't want to give them warm liquids by mouth. If you're working for a service that can give warmed fluids, certainly via IV, but don't give them just, a cup of hot chocolate if you're on your way to the hospital. If you have a patient that is going to be refusing your care, doesn't want transport, that's when it would be good to recommend, hey, drink some hot chocolate or maybe a coffee or something like that to help rewarm them from the inside out. But again, we don't want to give anybody things by mouth because we don't want to complicate any medications that could be given that can't if they just ate or drank something. Also, it complicates surgical cases as well. Extreme hypothermia, so patients that are unconscious, no discernible vital signs, their heart rate slows to 10 beats or less per minute, very cold to the touch. If they don't have a pulse, we're going to start with CPR and go through our normal CPR progression, normal code progression. If a pulse is present, we're going to care for any patient who is unresponsive or not responding appropriately. So rescue breathing, warming the patient up, etc. You're not dead until you're warm, and dead is kind of the saying. Certainly, if we do start CPR, we cannot call time of death. Not that you could anyways, but paramedics can't call time of death until after the patient has been adequately rewarmed, typically at the hospital in that particular instance. If your patient is unresponsive or not responding appropriately, we're going to ensure that the airway is open, provide high concentration oxygen, wrap the patient up in blankets, and transport them emergently. All right. Typically, when you go out in the cold and start to have cold weather injuries, the first thing that starts to happen is you get what we call chilblains, where your fingers and toes turn white, or kind of a splotchy red-white color. Fairly common, especially living in cold weather environments, for it to happen. It's not a medical emergency, but what it is the very beginning of there being the potential for cold weather injuries. So in those instances, when you notice that, hey, my fingertips are turning white, you start rubbing your hands together a little bit, you put on gloves, you get out of the cold, and whatnot, all right? Typically, the areas that are most affected first are going to be the farthest away from the core of the body. So the tip of the nose, the ears, the fingertips, the toes are all going to be affected first when it comes to these cold weather injuries. Blood flow is limited by constriction of the blood vessel. Tissues then freeze and may form ice crystals the colder and colder the skin gets. Early or superficial cold weather injuries would be considered frost nip. The treatment for this is to remove them from the cold weather and to cover them up. We would want them want to put them into a warm environment, but certainly, be careful about applying too much heat to the patient. We don't want to cause any damage to the tissue. So something that's warm, not something that's hot. Okay. Late or deep frostbite, this would be we're going to oxygenate our patients, cover the frostbitten part, and then handle it very gently. So when somebody has frostbite, their finger or the part is going to turn into kind of a black splotched area that's completely frozen, essentially. So this particular picture, this gentleman is probably going to lose at least all 3 of his fingertips, if not a little bit more of his finger, based on the fact that there looks like there's some frostbite a little bit lower down. Okay. Active rewarming of frozen parts. So this is very, very seldomly recommended, although it is something that's in your scope of practice. There's a huge likelihood of permanent injury with active rewarming of the frozen parts. Your local protocols may not recommend it. I don't think I've worked for a service that does. Partially because there's such a high risk, but the other part of it is because we have a very limited ability to do this correctly. So the steps include things like getting hot water from about 100 to 105 degrees Fahrenheit, fill a container with heated water, and then fully immerse the injured part in that water. Now, a couple of problems with that. One, how many of you guys have a good way to heat water accurately on your trucks? Oh, and by the way, it's supposed to be a steady temperature, right? So once we put the frozen part into this water, it still needs to stay about 100 to 105 degrees. So my guess is none of you have that ability on your ambulance. And if you do, I want to see your ambulance. I've literally never seen that. We want to fill a container with heated water. Well, how many containers do you have on the ambulance? Granted, we've got a couple of things that we might be able to use as a container, like a garbage box or bin. Maybe not the cleanest thing in the world, but we certainly could maybe try it. A lot of services carry bedpans. That might work, maybe. So maybe we could do that. Again, the heated water is maybe not the easiest thing to do. And then fully immerse the injured part. So things like our bedpans maybe wouldn't work well to fully immerse the injured part at all. We also don't want, when we do have it fully immersed, we don't want it to be touching the sides or the bottom. Also very difficult to do if you're bumping down the road, right? We should be stirring this water continuously, and if we complete the rewarming, we need to gently dry the area, apply dry sterile dressings, keep the patient at rest, continue to monitor, and then do not allow that limb to refreeze. So you might have noticed I skipped a picture a while back. This is the picture of it. It's, they used a garbage can with a bag, hopefully a clean bag, put the water in there, and then allow the foot to kind of soak. I really wouldn't recommend this in most cases, okay? The benefits are not really there. There's a lot of dangers that could be caused by this. There's just a lot of issues, okay? So be very, very cautious if you ever find yourself in that position to do that. So hot weather injuries or exposure to heat. So heat that's not needed for temperature maintenance and not lost creates hyperthermia. So essentially any heat that your body is holding on to and not able to get rid of the excess can cause this hyperthermia or excessive heat. If left unchecked, it certainly can lead to death. Kind of starts out with heat cramps, moves on to heat exhaustion, and then goes to heat stroke. So with heat cramps and heat exhaustion, you've got moist skin, pale to normal to cool skin conditions. Heat stroke, you get hot, dry, or possibly moist skin. So with heat cramps, usually what happens is your muscles start to cramp initially. Most people sit down, stop doing whatever exercise they were doing, and just take some water or Gatorade or whatnot to just try and get rid of the cramps, right? That's usually enough of a warning sign for most people. If you have heat cramps, that's the other thing, is you can kind of jump from just being normal to heat exhaustion. Heat exhaustion, you're still sweating, your body's losing salt. You can have cramps kind of on top of this. Most of the time, again, patients usually sit down and kind of try and self-regulate, but oftentimes they're not able to get cool enough, quick enough, and their body does things like has them pass out and such, at which point we usually get called. So weakness, exhaustion, rapid, shallow breathing, weak pulse, heavy perspiration, potential loss of consciousness. So our treatment for this is going to be to remove the patient from the hot environment, administer oxygen, loosen or remove clothing, put the patient in a supine position. If the patient is more comfortable with their legs elevated, feel free to elevate the legs. That is not something that we just do all the time. But if the patient requests it, or if they're more comfortable like that, certainly you can do it. It's not harmful for them. We're going to loosen or remove clothing, give them sips of water. Again, be very careful with that particular one. Apply moist towels over cramped muscles and transport the patient. Okay. Heat stroke is a true emergency. This is where the temperature regulating mechanisms of the body have now failed. The patient stops having the ability to rid themselves of excessive heat, and that heat is going to just kind of build up and build up and build up until the patient dies, essentially, if it's not taken care of. So this, usually a sign of this is the patient has stopped sweating. But be mindful that can be a little difficult to detect, especially if the patient was just sweating a minute ago. Sweat, unless you're continually wiping it away, will start to just kind of build up on the scalp, right? So if you wipe it away and it's not coming back, that would be a sign that they're no longer sweating. Loss of consciousness or altered mental status, shallow breathing, full rapid pulse, generalized weakness, dilated pupils. They also have a high risk of seizures as well. What we're going to do is take the patient out of the hot environment, remove their clothing, apply cool packs to the neck and groin. For infants or young children, cooling, we're usually going to start with kind of a lukewarm or a room temperature liquid. As opposed to adults, we can shock their system a little bit more. The system can handle it, and we'll start with kind of a cool liquid. Administer high concentration oxygen and transport immediately. As body temperature decreases, the muscles are going to, start to shiver. Heart is prone to dysrhythmias, and the central nervous system becomes sluggish. So that's with our cold weather injuries. We kind of switch back here to just do an extreme temperature issue. So that one's cold weather. Warm weather is on the bottom here. That's the sweating that leads to evaporation to cool the skin. If excessive heat builds up, the skin becomes hot, and there are issues. Okay. Questions on those heat-related injuries? Wonderful. All right. So weather or water-related injuries. So essentially, anytime you're in and around water, there's a plethora of things that could go wrong. Yes, it's a lot of fun, but even the things that we're doing to have fun, like boating or water skiing, can certainly cause some accidents and injuries. Things we need to be kind of on the lookout for: airway obstruction, cardiac arrest, heart attacks, head injuries, internal injuries, hypothermia, substance abuse, drowning, etc. are all things that we need to be kind of on the lookout for. All right. Drowning. So there are two different types of drowning. We can have fatal drowning and not fatal drowning. According to the World Health Organization, drowning is the process of experiencing respiratory impairment with submersion or immersion in liquid. Often what's happening is the patient is struggling to keep afloat. When they start to submerge, they try and take one more deep breath. Water enters the airway, followed by coughing and swallowing and involuntary swallowing of even more water, and patients often never resubmerge. Now, if they do, or someone pulls them out, if they've only taken on a little bit of water, oftentimes it's not fatal. It could be, but usually it's not in that particular instance. It's when they go under the water for an extended period of time that it becomes fatal. So a reflex spasm of the larynx is triggered when they inhale water. It's kind of sealing the airway. Eventually the patient will become unconscious, resulting from the hypoxia. Well, when somebody goes unresponsive or unconscious, they take one kind of final breath to attempt to get more air in, and when that happens, the lungs will fill with water, and the patient is a goner at that point. Rescue breathing in or out of the water, we never want to delay. We want to begin rescue breathing right away as soon as we can. If we reach a non-breathing patient that's in the water, we do want to support them in the best way possible, kind of supporting their head and neck, and provide ventilations that way. Now, we, as EMS providers, should never be in the water with our patients, period, especially if it's a natural body of water, all right? That you need additional training to do that, and we'll talk about that here shortly. Oftentimes when we're breathing for our patient with a BVM, if they've experienced taking on water or inhaling water, it will be difficult to breathe for them. You'll get quite a lot of resistance with the BVM. You can kind of tough through it a little bit, but it is a little bit more difficult than normal. So anytime we have a patient that's having a water-related injury, we're going to assume, unless we know for a fact otherwise, we're going to assume that they have a head and neck injury. Reason being, we don't know what happened, so we're just going to assume that they do. We'll immobilize the head and spine just in case, then call it good. We don't want to delay any of our care to care for the spinal injuries like CPR or airway, but certainly want to take it into consideration. Okay. Diving accidents most involve the head and neck, but they can also involve the spine, hands, feet, ribs, etc. The way that we would care for that is very similar to how we would care for any sort of traumatic head, neck, spine injury. Okay. Rescue breathing, CPR if necessary, spinal immobilization. Scuba diving accidents. So arterial gas embolisms, so this is when the diver kind of holds their breath. This might be due to things like inadequate training, equipment failure, underwater emergencies, or trying to conserve air. Kind of they get these embolisms, these gas bubbles that build up in their bloodstream and kind of work like a clot throughout their system, causing things like heart attacks or strokes or whatnot. Decompression sickness is where the diver surfaces too quickly from deep, prolonged dive. I guess the deeper they go, the slower they have to come back up, or they get this decompression sickness. Notice that it can take up to 48 hours to appear, which is why we might not have a lot of scuba divers in our area, but it's possible that they traveled back from someplace where it's more common to scuba dive, and now 48 hours later, they have symptoms of decompression sickness. Altered mental status, rapid loss of consciousness, blurred vision, seizures, paralysis, stroke, generalized numbness or weakness, frothing blood in the mouth or nose, incontinence, chest pain, etc. all kind of go under that decompression sickness, all right? Yeah, we kind of covered that already as well. Numbness, paralysis, choking, coughing, all signs. So the steps we're going to take: maintain the airway, administer oxygen, keep the patient warm, position the patient supine or on their side, continue to monitor, contact medical direction for any specific instructions, and transport them to the hospital as quickly as possible. All right. Moving on to water rescues, understand that this particular class is not giving you the training that you need in order to get into the water to help a patient, all right? That's a very dangerous situation, especially if it's a natural body of water like a lake, a pond, a pool, or a lake, pond, river, anything like that, streams. If it's like a backyard kiddie pool with 18 inches of water, you're probably okay, but big bodies of water we definitely don't want to go into. So the process, if you were to do a water rescue, is reach, throw, row, and go. So we're going to reach out to our patient with like a stick or something like that where we can reach to the patient and pull them in. We're going to throw something to them like a water flotation device and then pull them in. If you have the training to do so, you can row out to them onto a boat, or a boat out to them, and then go would be actually like going out to them as well. Ice rescues, kind of the same thing with this one. This particular class is not giving you enough education to perform an ice rescue. There are set classes that will give you that information. I strongly recommend taking them if they're an option for you to take. I've never had the privilege of being able to attend one, but I've heard some really good things, and especially, so I live in Prairie du Chien, right next to the river. You see fishermen out there all the time on the ice. It is something that is a bit big in this area. I would love to know exactly how to do it, but not something that I've ever been able to do. Number one rule with ice rescues is to protect yourself. Ways to reach the patient: throw flotation devices, toss ropes with like a loop in them. You can push out a flat bottom boat or lay a ladder flat on the ice. with these, our patients are going to be hypothermic, so remember that the patients may not be able to help much with the rescue process. We're always going to transport them. We never want to work alone, and we don't want to walk out onto the ice either. Okay. High altitude emergencies. So differences at high altitudes. The ability for us to diffuse oxygen into our lungs is severely decreased based on the air pressure. So when we have air pressure changes, our ability to breathe in that oxygen and get it where it needs to go is challenged. Room temperature. Oxygen should be about 21% of what we're breathing in at any time, but our ability to get that oxygen where it needs to go is decreased. Okay. Acute mountain sickness is a less serious case of a person experiencing problems adjusting to thin air. So in mild cases, all that may need to be done is just have the patient rest, rehydrate at that altitude, and eventually their body will kind of adjust to it. In more severe cases, we might need to give them supplemental oxygen and immediately descend from the altitude would certainly help as well. Now, HACE is high altitude cerebral edema. It's the worst form of acute mountain sickness. Symptoms would be headache, loss of balance, severe fatigue, seizures, altered mental status, and loss of consciousness. Our patient care would be to immediately have them descend from that high altitude. All other treatments are kind of secondary to this. Certainly we can give them some high concentration oxygen and then provide supportive treatment as well. High altitude cerebral edema is even more serious than HAPE, so signs and symptoms: shortness of breath, dry cough, tachycardia, mild fever, oxygen saturation, and respiratory failure. Patient care again is going to be immediate descent, administer high concentration oxygen, minimize physical activity, and provide supportive treatment. Bites and stings. So all spiders are venomous. Insect stings and bites are rarely dangerous unless your patient has an anaphylactic reaction. That's when we start getting majorly concerned. We want to remove the stingers quickly. Sometimes you can't always see them, so scraping across the point of the bite of the sting with like a credit card or something hard plastic helps kind of get that stinger up and out of the patient. This is an example of the brown recluse spider bite. I do believe we have these in our area, although I've never seen a brown recluse bite, knock on wood. It kind of starts out as just kind of a raw tissue that turns into a bigger and bigger area that eventually can become necrotic as well. So things that we should be on the lookout for with insect bites and stings: altered mental status, noticeable stings, puncture marks, blotchy skin, localized pain, numbness or tingling on the limb, burning sensations, redness and swelling, weakness or collapse, difficulty breathing, headache and dizziness, fever, chills, nausea, vomiting, muscle cramps, excessive saliva, and anaphylaxis. So the reason there's like 4 pages of this is because it's all insect bites and stings. It's not specific to one, like bees or ants or whatnot, right? It's all of them. Part of the reason why they did put them all together is because the emergency care is the same regardless of what bit or stung them. So treat for shock, call medical direction if we don't carry any or don't have a specific protocol for dealing with whatever they were stung with, remove the stinger or venom sac. Any sort of jewelry that's on the affected area, like rings, watches, even if it's like a cuff of a long sleeve shirt or something like that, anything that could be considered constricting, we're going to remove. And then we can place a constricting band above and below the sting or bite of the site, just not over a joint, if we're permitted to via local protocol. Now, that's not something I have seen on any of the protocols I've worked with. But again, I've never worked for a lot of the services you guys are going to work for. So it's quite possible that you do have that ability. And then keep the limb immobilized. Snake bites. So snake bites require specialty or specialized care, but they're not usually life-threatening. Stay calm. keep the patient calm and at rest. Apply kind of a pressure immobilization bandage to help slow that venom spread. We're not doing anything crazy like sucking it out. That doesn't work. If you've ever tried to suck out a flu shot, you would get essentially the same result. We should see things like noticeable bites on the skin or a noticeable bite on the skin, which may appear as nothing more than just a little bit of decoloration. Pain and swelling in the area of the bite, which may be, slow to develop, taking anywhere from 30 minutes to several hours. Rapid pulse and labored breathing. Progressive general weakness, vision problems, nausea, seizures, drowsiness, etc. Again, if we know what exactly bit them, we can call medical control or poison control, see what's going on there, what we can do. Treat for shock, keep the patient calm, remove any jewelry, keep the bitten extremity immobilized, and transport the patient. Okay. Poisoning from marine life. So this can occur in a lot of different ways. We don't have a lot of poisonous marine life here. Like, we don't have jellyfish here that I know of anyways. And please don't tell me if I'm wrong, because I don't want to know if the Mississippi River has that. But oftentimes when we're dealing with this particular category, it's usually from ill-prepared seafood or seafood that's gone bad and the patient has eaten. So in those instances, they'll have stomach flu-like symptoms, a lot of vomiting, diarrhea. We're just going to do our best to support the patient, oxygen if they need it, give them an emesis basin or bag, and take them to the hospital. But there's not a whole lot we can do in those particular incidences. If it is something like jellyfish sting or an urchin or something like that, you can do your best to remove the toxins on the skin, flushing with water. If there's any stingers still attached, if that's what they were stung with, you can go ahead and try and remove those. But in general, like I said, not something we usually see in this particular area. So that was the end of this chapter. All right.